everyone, I am Dr. Patibandla Shree National President, Society for Emergency Medicine, India. I congratulate Sri Lankan Society of Emergency Medicine for bringing up the unique workshop, Gender Equity and Equality, and how we have to bring this into our emergency departments. Very, very important workshop that every one of us should be aware of. And my heartfelt congratulations to Dr. Kaushila and Dr. Nilanka for bringing up this unique opportunity to Sri Lanka. Though I am unable to be available physically with all of you, my best wishes are always with you. Today, I will be talking on a different topic, that is gender differences in emergency presentations of our care. Do we have to apply a gender lens to our clinical guidelines? So as an emergency physician, we come across a lot of cases that walk into the doors of our emergency room, be it a trauma, be it a heart attack, be it a stroke. We take history, we investigate these patients, and we plan our treatments. But we are not taught to look at their gender at any point of time, because traditional medicine assumed men and women are same except for the reproductive organs. Many years, women are not included in the research because we have not considered there are any differences between men and women. So, as a result, 80% of the drugs that are withdrawn from the market are due to adverse effects on women. This male-driven research has led to a lot of adverse effects on women. One best example is zolpidem. Zolfresh is a common drug we have been using for insomnia, and after it has been introduced into the market, it has been noticed that this drug is staying in the women's circulation for a longer time than men, and we need to reduce the dose of zolpidem for women. As a result, there is a recommendation that when you are prescribing zolpidem to women, we have to give half the dose only. So, why is this happening? After a thorough research, why is this happening, or why are these changes happening for women after releasing into the market is because there is a requirement of informed consent, and women of childbearing age will have a lot of hormonal changes that might affect the drug interactions, and men are always considered as homogeneous, and this led to a concept that whatever works on men will work on women also. So we considered men and women as equals except for the reproductive organs, and this led to all the research that has been happened so far. So this led to the concept of bikini medicine, where except for reproductive organs, men and women are considered equal or the same. Just like how when the pediatric specialty has started, children are considered as the little adults, the same concept has been happened for gender as well. So after a lot of research, this led to the evolution of gender-specific medicine. When Dr. Maren J. Legato, she is the pioneer of research in gender-specific medicine. In 2004, she was asked by American Heart Association to look at how heart diseases are different between men and women. So when she was given this task, she thought, what differences will have? It's all blood vessels and myocardial cells. But when she started the research, it has been an eye-opening for her as well. And she has extended her research not just for heart diseases, but the entire textbook of principles of gender-specific medicine written by her has been into force after that. So what does gender-specific medicine does? It examines how normal human biology and physiology differ between men and women, and how diagnosis and treatment of diseases differ as a function of gender. So what is happening in emergency medicine? We see a varied number of presentations, and the eye-opening for emergency medicine is 2014 Academic Emergency Medicine Consensus Conference, which is the first step in identifying gender-specific care, is important in emergency medicine as well. As you all know, we see a lot of cases. Every specialty is involved in emergency medicine care. And whether we order tests or prescribe medicines, we never thought gender is important because we were not taught in our medical schools. So gender-specific emergency medicine is a specialty that is coming up now because we have to consider gender, whether it is for clinical features, diagnosing conditions, interpretation of the lab tests, or the treatment titrations. Everything has to be considered. And once it starts in the emergency room, it benefits larger population over a short period of time. So what all gender-specific emergency medicine comprise? We all know women's reproductive health and men's reproductive health, but what sex and gender-based medicine considers is how do we manage these patients in resuscitation, cardiac arrest, or some acute presentations, and drug metabolism and metabolic diseases, and cardiovascular, skeletal, and other diseases is what we are going to concentrate now. So the few presentations are going to be on these important aspects what we are going to see on a day-to-day practice. So we'll go with the case scenarios. A 65-year-old female with exertional breathlessness for 1 year with one episode of fever with chills after traveling to her native place developed SOB for 1 to 2 days. She is a hypertensive, hypothyroid on treatment, non-diabetic, and recent health check has showed triglycerides of 295 and did not do TMT because of her knee pains. ECG was taken in ER was showing non-specific, no STT changes, and TROP is negative and echo showed no RWMA. This is a real case scenario, and she is my music teacher during my school days and a celebrity's mother as well. And this is her ECG, and her TROP is within normal limits, and ECG was showing no RWMA. So with the gender-specific medicine in my background, I advised CAG for her. There was a struggle. You know, the cardiologist said, TROP negative, echo normal, why are you putting her to angio? And family, being a celebrity family, they said they have a known doctor outside. It took almost 6 days to convince her to get a CAG done because her symptoms are not getting resolved. And a CAG revealed near total critical occlusion of proximal LAD and underwent PTCA on table. So this is her PTCA report. So why are these differences coming? We all know chest pain, which is very typically described in our textbooks, is all of us know, but in women we will see different presentations. It can be just generalized weakness, shortness of breath, or vague symptoms like jaw pain. All these are the manifestations of a cardiovascular disease in women. So we treat very less aggressively when it comes to a woman, and they undergo less stress test investigations, and then eventually angiogram and revascularization also very less in women. Then another case, 43-year-old female presented with left-sided chest pain for over 40 minutes, and she had CVA 2 years ago and a hypertensive. This was her ECG, which is typical, that is showing STT changes, but echo and TROP are negative. And 1 hour after sending this patient to cath lab, the repeat ECG was showing this, and her chest pain also resolved. She underwent CAG, which showed it is a triple vessel disease requiring CABG because left main artery also is involved. So why are these changes happening? So there are a lot of studies that show us that there are differences of presentation, differences of ECG patterns that are seen between men and women. So there is a statement from AHA which elaboratively states that there is a difference of acute myocardial infarction in women. So when it comes to risk factors for men, we say hypertension and dyslipidemia are the common risk factors for men. But when it comes to women, diabetes, smoking, metabolic syndrome, depression, autoimmune diseases, or pregnancy-related complications like eclampsia or gestational diabetes are predisposing for women to get cardiac diseases. Coming to pathophysiology, in men we all know plaque rupture that is leading to ST elevation. But in women, it is endovascular dysfunction or erosion that causes, or coronary artery spasms or dissection. So when there is a spasm, you get ECG changes. When the spasm is released, you might see a normal ECG in these people. So these are very common in women. Ischemia with non-obstructive coronary arteries or myocardial infarction with non-obstructive coronary arteries are very, very common and are undiagnosed or underdiagnosed in women. Coming to the troponin assay. The troponin assay is very commonly used in emergency rooms, and it is very evident that it is consistently lower in women. So when you see a normal troponin level, we should always have a suspicion that this could be because of the gender differences that we are seeing in women. So the peak tropi levels are 4-fold lower in women than men, and this is the reason why women undergo less PTCAs. So any emergency physicians looking at tropis in women, you should always have an extra suspicion that normal troponin levels will not rule out cardiac disease in women. So this should give us an opportunity for aggressive screening, and you always use newer diagnostic models. Even if the tropi is normal, if the patient is coming to us with symptoms, always take that extra step to put them to a newer diagnostic modalities like CT angio or CAG, and advise them for periodic health checks and set a tone from the beginning that there can be gender specific differences. Your tropi normal is not that I am going to send you home, is what we have to set the tone in emergency itself. Then another case, a 51-year-old presented with right-sided numbness and noted to have high blood pressure of 220/120 at home. She is a known hypertensive and has been using homeo medicine, alternative medicine, and stopped using any medications 4 months ago. There are no other neurological deficits on presenting to emergency room. They came at around 11 p.m. brought by her son and asking for a BP medication because BP recorded at home is high. We asked for an MRI brain. Attendants are not convinced. We just give us BP medication, we'll go home. So after 2 hours of bargain, they finally agreed to have an MRI brain, and MRI brain revealed this: capsuloganglionic bleed of 2.9 into 1.8 centimeter with diffuse microangiopathy in both cerebral hemispheres. So she was finally admitted and managed conservatively and discharged in a stable condition. The reason I am pressing this is, when it comes to a man in emergency room, the admission is very easy for ER physicians. But when I have to admit a woman, there are a lot of social factors also come into place. Kids at home, or managing home is difficult. All these conditions also play us and will be taking our judgments as well. So there are differences between age and gender in acute stroke patients as well. And all these things, the full-blown hemiplegias are not seen in women. By the time we see full-blown hemiplegias in women, the damage that has occurred has already been very, very bad, not just like in men. So we have to consider these differences as well when we are treating women in the ED. Then coming to the regularly seen emergencies like sepsis, trauma and shock, there are differences. So in a premenopausal and men, there is a 17 beta estradiol levels which are high, which will help in protecting the end organs when it comes to acute emergencies. In postmenopausal women, the 17 beta estradiol levels are lower, and which will make them prone for end organ damage very early in these patients. So this has been studied how 17 beta estradiol administration can help in reducing inflammation and improve function and vascular responsiveness in these patients. Then coming to another case, a 55-year-old obese female, hypertensive, diabetic, presented with high-grade fever, altered mental status and hypotension in emergency room. This patient needs endotracheal intubation. Are there any gender differences to be considered? So we all know that the size of ET tube should be lower in women. Any other differences that need to be considered? The drugs that we use in endotracheal intubation. So the routinely used drugs like rocuronium has to be given in a lower dose in women, and it stays for a longer time in women's circulation. So the paralytic effect will be prolonged in women. So females require 30% less dose of rocuronium, and the duration of action is more. Coming to vasopressors, again they metabolize differently. The protein that metabolizes vasopressors is 25% more active in men. That means to say that men require higher doses of vasopressors than women. Then a case, you are asked to give a procedural sedation for a 55-year-old female with right shoulder dislocation. So the previous experience in emergency room with midazolam was bad, where the patient had gone into respiratory depression. So now we have chosen propofol. And With a bad experience, you always try to give lower dose, 1 to 2 mg is the dose and 1 mg of propofol was given. So what happened next? Patient is not sedated properly and then a top-up was required. After brief sedation, patient again woke up and before the procedure is completed. The surgeon is frustrated and asked to call an anesthesiologist. So we had to give LMA is inserted and ketamine and propofol top-ups were given and procedure went successful. So when you are retrospectively realizing what happened for this patient, it is known that women wake up from propofol faster than men. So due to variations in body size, composition and drug metabolism and clearances, all these will play a role based on the gender as well. So what are the drugs that you have to be careful with? Lipophilic drugs, because of higher percentage of body fat, they should receive higher doses. So women should receive higher doses of propofol because of large volume distribution and lower plasma concentrations. Then hydrophilic drugs, we should always give them on a lower doses like midazolam, rocuronium and other neuromuscular blockages. You should be giving lesser dose in women than in men. And vasopressors again should be lowered in women. So patient, after the procedure, patient was observed because LMA is inserted and patient was discharged home. Patient called back stating she developed sore throat and hoarseness of voice post-procedure. Surgeon is worried that ER didn't manage this patient properly and didn't give sedation appropriately. So all these complications happened. Very common, ER being targeted, right? So there are differences of gender differences exist for endotracheal intubation and LMAs. Sore throat and hoarseness of voice are very common within 24 to 48 hours. The first 24 hours with LMA, women experience more sore throats and hoarseness of voice. When it comes to ET tube, the first 24 hours is the same for both men and women. But as the days pass by, women experience more hoarseness of voice and sore throats. So LMA carries higher risk of sore throat in women and incidence of hoarseness of voice increases in women after 24 hours of extubation. Then coming to another case, a 65-year-old alleged history of drowning while crossing a canal, unconscious and CPR done outside and no respiratory efforts, so intubated in the emergency room and peripheral pulses not felt except for the carotid. She was put on inotropes, pupils reactive and paucity of movements in all 4 limbs. So this was a case I have managed almost 15 years ago during my early years of practice, and there has been a constant force from the attender. She is a widow, she doesn't have kids. So the husband family has come, started asking us to remove the ventilator, and her family has come, brothers has come asking to continue. Finally, after almost 15 to 20 days, she was discharged home successfully. The reason why I brought this is, when it comes to end-stage diseases or cardiac arrest, women receive less CPR and less aggressive resuscitations as well. There has been evidence that shows that they are less likely to be resuscitated and survive after cardiac arrest than men. So non-shockable rhythms are common in women, and women are 3 to 5 years older than men by the time the cardiac arrest sets in, and less likely to have a witnessed arrest. Most of them will be living alone and they receive less aggressive care. Bystander, BLS and early defibrillation are very, very less for women when compared to men. And early withdrawal of care is seen in women than in men. And again, as I already mentioned, they are underrepresented in random control trials that led to lesser research as well. So coming to CPR training, we all have mannequins, but there may be a future where we need to have mannequins where we will train them how we have to perform CPR in women as well. So what does this evidence teach us? Whatever we have seen in the last 20-30 minutes is just a tip of the iceberg of the common presentations we are seeing. But next time when we are seeing, we have to utilize this for our clinical practice, and this should be a game changer in our day-to-day practice as well. So this requires the researchers, clinicians and medical educators come together to formulate our clinical guidelines with a gender lens as well. So this will be the concept of GSEM that comes into place. So this is not just about a woman's health, it is about a personalized, individualized care for everyone. So this is the message I would like to end with. By treating women differently, we are giving a gift to men that, we are bringing up a personalized, individualized care to everyone. Thank you.